And also, you don't want this patient to pee. You want them to be anuric or to be oligouric, because you've got hypotension. You cannot afford to lose water through urine. So this ADH will make sure that there is no water that escapes through the urine. And then there are other effects as well, but these are the most important ones for our talk. So guys, this is very important. This is very, very important. We have to understand it. So let me just clear space, guys. So we now know that we have hypotension, and this hypotension resulted in the activation of the RAAS system. And we know now the pathway, but I'm gonna jump. Let's say now we have our aldosterone having been released, and aldosterone is the magic hormone that's gonna help us to retain water. What's gonna happen is that aldosterone is going to go to the kidneys, this is the nephron, our collecting duct. So that's this is the Bowman's capsule, and then we have our afferent arteriole and our efferent arteriole, and we've got that mesh that is there. Then we've got those blood vessels that run like that. We've got our proximal convoluted tubule, descending loop of Henle, ascending distal convoluted tubule, and then your collecting ducts. So what's going to happen is that aldosterone is going to act on the ascending limb and also on the distal convoluted tubule. What it's going to do is that, so as part of the filtrate there, you get sodium that enters the nephron itself, and this sodium is going to be excreted in the urine. But when aldosterone comes, it's going to make sure that sodium is absorbed back into the circulation. Sodium is going to be absorbed back into the circulation. When that happens, the chloride ions will also follow, and automatically water will follow the sodium. Now, that's why they say aldosterone causes reabsorption of sodium. Reabsorption of sodium and water. So what aldosterone actually does is to cause reabsorption of sodium. Because sodium is married to water, water is going to follow sodium. Wherever sodium goes, water will follow. So now this patient, when you allow this to happen on all of those nephrons and long enough, the water that you lost that gave you hypotension, let's say you were the blood that you lost, maybe you were vomiting or you were bleeding. So the hypotension that you had, which is a low blood pressure, remember guys, BP is equals to cardiac output multiplied by peripheral resistance. And we know that stroke volume is a product of, cardiac output is a product of stroke volume multiplied by heart rate. And we also know that what makes stroke volume is preload. Preload, contractility, and afterload. So those are the things that contributes to a stroke volume. Now, when you are absorbing a lot of water back into the circulation, what you're going to do, you are going to, let me just finish it off. So one of the things that contributes to a preload is blood volume. Remember, the more blood you have, the more venous return you will have, and the more venous return you have, the more preload you will have, and the more preload you have, your stroke volume is going to increase, cardiac output is going to increase, and then eventually your blood pressure. So the body knows that if I have hypotension, I've got a hypotension, if I can make sure that I don't lose fluid, I retain my fluid and absorb more water, blood volume will increase. If blood volume increases, venous return increases, then preload increases, then stroke volume increases, cardiac output becomes better, and our blood pressure starts to go up or become normal. That's the thinking behind. So when your aldosterone has been released, it causes reabsorption of sodium, and then water follows, and then now the more water molecules you reabsorb, your blood volume will increase, and this will increase this guy and that guy and that guy and this guy, and then you get to a state whereby you have achieved normotension. Once you achieve normotension, this RAAS system will shut off again. It will shut down, or it's going to be switched off until again you experience hypotension. Then the same thing is going to, then the whole cycle will start again, the pathway and all of that. Now, look at what happens here. Some people say that one of the reasons, one of the causes of the release of aldosterone is hyperkalemia. Aldosterone is also a good hormone when it comes to regulating potassium. How does that happen? Okay, the sodium potassium pump here, the body knows that if I absorb a cation, it means I must let go of another cation so that I can maintain electron neutrality. So if you reabsorb sodium, then potassium will have to go the other way. Now, that's how aldosterone is able to normalize hyperkalemia, because when sodium is reabsorbed, another cation has got to take the fall, or has got to be released, or has got to go the other way, and that cation is potassium. So you will get potassium going the other way. This patient will excrete urine that is very high in potassium. Okay, that's what I need to just put it on record and just yeah. So now, guys, we have seen that aldosterone, or the RAAS system, what this system is concerned about is increasing blood pressure. That's what it's concerned about, increasing blood pressure. So now, if you've got a patient, so it increases blood pressure by doing what? By making sure that sodium water reabsorption occurs. So this system knows that if water reabsorption increases, blood volume will increase, venous return will increase, preload will increase, stroke volume will increase, cardiac output will increase, and then BP will increase. Now, when you've got hypertension, you already have a high blood pressure. So now, retaining more water will not do you any good. So, this system is horrible for a patient who's hypertensive and has got CCF. It's a bad system. Because, remember, when you've got heart failure, you've got some hypoperfusion, a low degree of remember, especially if you've got cardiogenic shock. Because when you've got heart failure, the pumping ability of the heart is affected. So you have a small degree of hypoperfusion. And it has been researched, it's well documented that the RAAS system is chronically activated for heart failure patients, and that's why we use ACE inhibitors to switch it off, to switch that RAAS system off. So you have a system that is excited, that loves to increase blood pressure, and it does that by causing water retention. Now you already have high blood pressure, so you don't want to retain. Remember, one of the medications that we use for hypertension is diuretics to make the patient to pee. But this system is making sure that it's fighting your medication. So that's what I'm saying. The RAAS system is horrible for CCF, is horrible for hypertensive patients. You give diuretics to make the patient to lose water. But this system comes in and makes sure that the patient retains water. That's why when you've got and now you've got CCF patients. A CCF patient is fluid overloaded. They've got a chronic fluid overload state. Now, when you've got fluid overload already, and then you switch on this system, you are saying to this patient, retain more water. The same water that is making the patient to have pulmonary edema, the same water that is making the patient to have swollen limbs, congested liver, and all those things. So that's why I'm saying this system for CCF and hypertension is horrible. You don't want it in those patients. And thanks to ACE inhibitors are able to switch off this system. That's why having a patient who has got CCF, who's not on an ACE inhibitor, who doesn't have any contraindications, it still puzzles me even today. Because it's been proven that ACE inhibitors are the anti-failure drugs, are one of the anti-failure drugs. There are others, there are beta blockers, there are so many other classes of drugs. But the ones that are easy to find everywhere in South Africa is your ACE inhibitors. So, like I said, that with a CCF patient, you've got fluid overload. You want to get rid of that water. Now, activating this system, you are retaining more water. And also with a hypertensive patient, you already have a high blood pressure, and by retaining water, you are going to increase this blood pressure more. So you will never win, right? That's what I wanted to get to. We are still going to answer the question, why is high salt intake a problem in heart failure and hypertensive patients? I hope you can appreciate, and actually I hope you learned something from this section. Very, very important. Please guys, if you haven't watched my video where I explain antihypertensives using this formula, please go and watch that video. It's the most successful video that I've ever uploaded on YouTube. It has got about over 330 views. I use this formula to explain all the antihypertensives. And this formula, if you know this formula, you know how all the antihypertensives work, because those antihypertensives, they just manipulate the peripheral resistance and the cardiac output to decrease your blood pressure. Okay guys, let's meet in part 3 of this video, of this talk. Thank you.